So, good evening, everyone, and welcome to today's SANS Medical Student Chapter Education webinar held in recognition of International Epilepsy Day. Ramadan Kareem to everyone joining us this evening. My name is Ragad Al-Mtairi, head of the Logistic and Organization team under the SANS Medical Student Chapter, and I am joined today with my co-head Payam Sidhu. So, in recognition of World Epilepsy Day, it's our honor to introduce our esteemed guest speaker, Dr. Afnan Alkhotani, Functional and Epilepsy Neurosurgery Consultant at King Faisal Specialist Hospital and Research Center in Jeddah, and Assistant Professor at Al Faisal University in Riyadh. Dr. Afnan specialized in functional and epilepsy neurosurgery, focusing on surgical management of epilepsy and advanced neuromodulation technique. Her work aimed to improve seizure control and enhance patient quality of life. Alongside her clinical work, she is actively involved in teaching and research, contributing to advancement in epilepsy care. Please join me in welcoming Dr. Afnan Al-Khotani. We're honored to have you with us today and excited to learn from your expertise this evening. Dr. Afnan, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for the kind introduction and كل عام وأنتم بخير ورمضان مبارك. It's my great honor today to contribute here to the Epilepsy Day, as it's truly a part of my passion toward neurosurgery is the epilepsy surgeries, which are like devastating disease, which is not only a disease, it's a condition that affects the whole family and then the society. So as you mentioned before, I'm Afnan Alkhotani, consultant neurosurgeon at King Faisal Specialist Hospital Research Center, Jeddah. I'll speak about the surgical part of the epilepsy with some brief information about the medical part. So those are my objectives to highlight throughout the speech, and feel free to interact or write your questions in the chat box where we can come to visit later on. So speaking about epilepsy, epilepsy is a condition that affects people, not only the person, but the whole family. It's unpredicted, unprovoked seizures that has certain condition, and it happens with a certain recurrence rate. So it needs to be diagnosed by an epileptologist to confirm the diagnosis. Or it might be associated with epilepsy syndrome, which is genetic syndrome, whether the gene is very well recognized or not. And this is another hot topic for further future management for epilepsy, for genetic epilepsy. About the epilepsy, it's just like thinking about an epilepsy. If you imagine the brain and where it's composed of certain cells or millions, billions of neurons, and there is one hypersynchronized neuronal firing. It's just like a house inside a big city where it gets fired, and it's it's your task whether you can eliminate this fire or contain it, or it can spread to all the surroundings and burn everything. So it's not like a neuronal firing by itself, but it's the circuit or network disease. It has some contribution to excitatory or inhibitory imbalance, and it can be structural, caused by tumor, vascular injury, happen de novo in life, or genetic, born with, metabolic or immune causes. So it has a variety of possible causative agents. But generally, it's a network disease where it has a generator and then a spread of the disease. So our target here is to identify the generator of the epilepsy in order to contain the disease spread. So there are some certain portion of the patients who develops resistance to epilepsy even after two appropriately selected anti-seizures medications. and receiving the third medication will have very low probability of controlling the seizures afterwards. So those are deemed as drug-resistant epilepsy by default, and it occurs in 1/3 of the patients. So this is just to remind you that I'll go through some companies' names or brands for certain devices or drugs. So it's just for educational purposes. About the epilepsy in Saudi Arabia, you know that our prevalence is 6.5 per 1,000 individual, which is quite equivalent to the prevalence in United States. And this is very comparable result all over the world. For the pharmacoresponsive versus pharmacoresistant epilepsy, they contribute about 1/3. And those 1/3, unfortunately, it takes them about 17 years to reach the appropriate service or refer to specialized higher center for epilepsy surgeries. Only 1/3 of the refractory patients they reach us. And we need to work on bridging this gap by more awareness about the disease and the possibility of curative surgeries. So this is in King Faisal Specialist Hospital. We're receiving this tertiary care or advanced cases where we start with identifying patients with drug-resistant epilepsy. They undergo video EEG plus imaging, and when there is a good uniformed hypothesis about unifocal epilepsy, we formulate the hypothesis and we initiate the planning for possible invasive or non-invasive imaging. After that, if we needed the invasive techniques, we go to invasive, whether with subdural electrodes, ECOG, or stereotactic EEG, for further delineate the location of the seizure focus in the whole 3D geography of the brain, as most of them are structurally normal, but they are electrographically abnormal. And then if we identified the focus, and the focus was in a non-eloquent area. Non-eloquent means the non-functional area of the brain, or an area of the brain that is amenable for resection without further deficit. Then we can execute the surgery. So we will go through the indications for epilepsy surgeries in brief. If the terminologies were quite advanced for you, I would like you to just write them down and ask me by the end of the lecture about it. So the epilepsy becomes surgical when they fail the medical treatment, or there is epileptogenic zone that is very well recognizable by EEG. Or there is acceptable risk-benefit profile for the surgery, as sometimes we identify the seizure or epileptogenic zone, but we cannot resect it because it's functional area like speech or like executive function or motor function of body. Or if there is progressive structural lesions, like in tumors or vascular or post-traumatic insults. So for the epilepsy surgery evolution over years, it went from the ECOG to SEEG and then the subdural electrodes, and nowadays we are more into spatiotemporal zones for ictal identification dynamics. So what is the meaning of epileptogenic zone? If we see here the picture of the brain, there is some geographical distribution around the central sulcus. For example, here is the language area, the Broca's, and here is the Wernicke language area of the temporal lobe, the motor, and the comprehensive. And then there is the central sulcus in the dark black. In the front is the motor, in the back is the sensory. So identifying the ictal onset zone, epileptogenic zone. Epileptogenic zone can be including the ictal onset zone plus plus the epileptogenic zone, which is a bit larger than the lesion itself. So the area around it, it can be called the functional deficit zone. You cannot resect all of the functional deficit zone. If you resected only the epileptogenic zone, it's fine. It's curable. But if you resected the ictal onset zone only without the epileptogenic zone, you failed the surgery. So we need a bit larger than ictal onset zone and smaller than functional deficit zone. So it is the area which is the epileptogenic zone. You will hear this terminology throughout the presentation. So epileptogenic zone is the area of the cortex indispensable for the generation of seizures, whereas the ictal onset zone where the seizures are generated. And irritative zone is the surrounding area. Symptomatogenic zone, if the seizure happening from here, the first symptomatic zone is the sensory and motor cortex. So the patient can manifest it by some tingling sensation, followed by myoclonic seizure on the facial or upper limb homunculus, according to the semiology of the area of the seizure. And then the functional deficit zone, which is even larger than the epileptogenic zone. So all of them are larger than epileptogenic zone, except the ictal onset zone is more concise, whereas the epileptogenic zone is the electrically active area, because if there is dysfunctional neuron, but the surrounding is the epileptogenic zone. If there is a tumor, the neurons are silent, but the surrounding area is epileptogenic zone. If there is cavernoma, for instance, it's silent, but the surrounding hemosiderin capsule is irritating the neurons around it, and it is causing the epileptogenic zone. So it is a bit larger than the lesion, and it is the target for resection. So here we're talking about epileptogenic zone in more details, and it is usually captured by EEG or sometimes the MRI if it's visible. It's much larger than the area seen in MRI. That's why we're using ECOG or stereotactic EEG. So how to evaluate the patient if the patient has refractory drug-resistant epilepsy? We start with imaging, non-invasive imaging like MRI, CT scan as needed. MRI protocol for epilepsy. It is thin cuts around the coronal area over the hippocampus and temporal lobes. Also, after that, we get the patient to have an EEG, whether interictal EEG or long-term monitoring in EMU, Epilepsy Monitoring Unit, where we capture some seizures after stopping the patient's medications and have some pictures to see the patient movement and describe their aura, feelings, and also see their movement. So we can lateralize. If they move the right side of their body, most likely the ictal onset zone is on the left side. If they move the right side, the left side of their body, most likely it's opposite on the right side. Also, if there is a speech arrest, it gives a hint that the seizure onset zone is on the dominant hemisphere. If they have visual hallucination or some structural abnormality, so we can redefine the seizure onset zone as occipital, fusiform, etc. So this is about the video EEG. So it is needed to be performed like with the patient's movement over the video camera. In the same time, we need to see whether this is real seizure. So we have also connect the patient to EEG, scalp EEG. So when there is electrographic seizures where there is a spikes and wave, and also seizures manifestation like some lateralization, fencing, or clonic seizures or tonic seizure or whatever. So we have to have both in the same time happening. So it is real seizure, not a pseudo seizure or psychogenic seizures. Okay. And then also another step is the neuropsychology. Neuropsychology, we can get a baseline IQ, baseline verbal memory versus visual memory. And also we can detect the level of cognitive functions. And if there is a deficit in certain hemisphere, it can localize or lateralize also the dominant hemisphere by neuropsychological testing. So it's a crucial element as a baseline assessment, and also a prognostication or diagnostic tool to lateralize or localize. And also it gives some prediction about how much loss after surgery can happen. So it's really important. The last one is the nuclear medicine, where PET scan can show where we inject some radioactive materials and get a CT scan of the brain and see how much this area is not taking too much of those radioactive material. On PET, it's interictal, so there is hypometabolism in certain area of the brain. Whereas the SPECT, when we get the patient inside the epilepsy monitoring unit, if the patient has the seizures on the electrographic, we just inject the patient with the radioactive material and get the patient to the CT scan and capture the image. When there is hypermetabolism in the SPECT on certain areas or certain lobe on the brain, we recognize this area as the area of interest of or the epileptogenic zone. So both are giving some hints: PET by hypometabolism, SPECT by hypermetabolism. So as I tell all of my patients in the clinic that epilepsy surgery is a journey. So we start by thorough history, physical examination, EEG manifestation also. And we formulate a hypothesis, and then we get a video EEG, then we get the neuropsychology evaluation. We meet all together the neurosurgeon and who's doing epilepsy surgery, as it is a subspecialty in neurosurgery, and also the neurologist who's specialized in epilepsy. And then we have the neuropsychologist if available in the hospital, and also the neuroradiologist, and plus minus pediatric epileptologist as well. So all of those people, together with the residents and fellows, we meet and we review the patient's interictal EEG, ictal EEG with the video, and MRI, PET scan, SPECT if there is, and also MIG sometime can help, which is like an EEG, but instead of electrical capture, it's a magnetic capture of spikes and waves. I'll show you some pictures later on. And then we decide whether the patient needs further investigation with invasive testing or goes right away to surgery. And after that, if the surgery is resective or neuromodulation or ablative or disconnecting, disconnective, depends on the further finding. So each epilepsy surgery is not one operation. Sometimes we do operation and we keep the patient, we revise our hypothesis. So then we personalize or we tailor the intervention according to the patient's condition. So no one patient like the other, no one case similar to the second one. Each case is very unique on its own. The SEG is the invasive monitoring, where we insert some electrodes and we map the area of hyperactivity, and then the network mapping with the subdural or ECOG or SEG. It provides some minimally invasive but highly precise localization for the surgery. So the types of surgeries in general, they are resective, disconnective, neuroablative, neuromodulation. When we start with resective, resection is the best when it comes to the seizure freedom chance, whereas it carries the highest risk of permanent neurological deficit because it's a major brain surgery. What are resective surgery like? like functional hemispherotomy, temporal lobectomy, extratemporal lobectomy, lesionectomy, modified regional resection using SEG, ECOG, navigation, MEG, or PET. This connection is in the middle. It's just like separation, two hemispheres, or مثلا one lobe from the other. And the ablation is the radio frequency lesioning or laser interstitial thermal therapy, where we burn the focus and leave it inside the brain. The neuromodulation is where we insert some electrodes to modify the electrical activity and act accordingly. So when we move to neuromodulation, it carries the lowest risk, but lowest seizure freedom, and also it carries the lowest risk. So you don't create a lot of permanent deficit from the neuromodulation, but you don't have the best seizure outcome from the neuromodulation. So neuromodulation, you can think about it as the weakest, and resection is the strongest, but neuromodulation are the safest, but resection are the best. اتفضلوا, somebody is raising hand.
السلام عليكم.
Yes, وعليكم السلام ورحمة الله.
رمضان مبارك. حابة بدي أسأل سؤال about epilepsy surgery.
تفضلي.
في ال temporal lobe epilepsy we have olfactory hallucination, epigastric sensation. So why can a patient with temporal lobe epilepsy considered for surgery motor cortex is normal?
Yeah.
يعني ما في مشكل في الموتور cortex.
It's the temporal lobe is away.
The temporal lobe is away from motor cortex. So
you can lower
my voice.
Yeah, thank you. So temporal lobe, it has certain anatomy. It has the superior temporal gyrus, middle and lower, and there is a fusiform gyrus in the basal part, and then the endorenal or parahippocampal gyrus mesially, and then we have the mesial amygdala and hippocampus mesial temporal structure. So they are close to the smelling area, and it is causing those abnormalities. They are away from the temporal, away from the motor cortex. For that reason, we're not afraid about the movement per se, but it is close to the Wernicke area, so we are concerned about the speech. That's why we request functional MRI. And also it is close to the Meyer's lobe, which is part of the visual pathway. When we have the two optic nerves and they do the chiasm, and then they do the optic radiation, and then till they reach the occipital lobe, they have those lobes, which are the Meyer's lobes. So resection of the temporal cortex can cause deficit in the Meyer's lobes. We'll cover later. Hello. We're good. My voice is clear.
Yes, it's clear.
طيب, thank you. So I'll come into details, inshallah, to answer all of your كده questions, just to make it as simple as possible. So for the resective area, resective surgeries, they are the best. Always resection is taking the seizure focus outside and looking at it under histopathology to find out whether this area has a tumor, has focal cortical dysplasia, which is abnormal migrational disorders since birth, or vascular abnormality like cavernoma or any other tumor. طيب, so this is for the resective surgery, is taking part of the brain outside. We can do it if it is safe to do so. We call it eloquent area for the area that we cannot resect. Non-eloquent is the area that we can safely resect without any deficit. So for the temporal lobe, the outcome is very good. It reaches up to 80% if we resect the seizure from the temporal lobe. Whereas in the extratemporal, like in the frontal, parietal, occipital, it drops to 60% chance of seizure reduction if we resected that part of the brain. So the temporal is high fortune or the best fortune for the epilepsy patients, whereas extratemporal is quite difficult ones. What we have types of resection, we have anatomical hemispherectomy, which is rarely done. Why is that? Because we don't want to create hemosiderin deposition like they have done it in the past, but it creates hemosiderin deposition, and this causes death to patients. So what we are doing now is disconnection hemispherectomy instead of anatomical hemispherectomy. We call it functional hemispherectomy. For resection, the temporal or extratemporal lobectomy or lesionectomy for the lesion itself, or modified regional resection with using SEEG guidance, stereotactic EEG implantation. I'll show you that in the coming pictures. Echo-guided resection, where we use certain electrodes on top of the brain, or navigation-guided, or MIG, or PET, or etc. So sometimes we do lesionectomy only if there is no interictal. يعني if we did EEG and there is no interictal, we get the patient into EMU, there is no interictal. So we do lesionectomy with a safe margin, as limited as possible. For the SEEG implantation, which is the robotic SEEG, it's more of an AI improvement in neurosurgical field. So it's meant to enhance the capability of the neurosurgeon, not to replace, but to enhance, to make it more precise and more accurate and more time saving. So we identify the patients of interest according to the hypothesis. If we have the seizure likely on one hemisphere, but we cannot tell which lobe, but مثلا we have more likelihood of being anterior quadrant, posterior quadrant of the brain. So we implant those area according to the hypothesis presumed. So this is the robot running show, and this is the O-arm where we do the registration with the frame, and this is the quality check after with the laser after registration to make sure that the accuracy is excellent. And then here after draping, we cover the patient, and here all of our implants and drilling and the stuff for further execution of the surgery. This is an example of MIG, magnetoencephalography, which is like an EEG, but from magnetic point of view, which is more than more of depth 3D, and it has certain way of understanding it, and there is a special doctor to read the magnetoencephalography. This is a collaboration with King Fahad Medical City in Riyadh. Dr. Vahi is performing this MIG for our patients in Jeddah. So this is one example about 32 years old lady, right-handed, known as left hemispheric epilepsy. As you see here, it's on the left hemisphere. Her MRI was negative. That means the frontal lobe has seizures, but electrically abnormal, but imaging-wise, it's normal. Seizure description, there is no aura. So the seizure composed of aura, بعدين semiology, and then post-ictal, whatever. NAS post-ictal sleep, post-ictal whatever. The aura is very good indicative for the seizure origin. يعني إذا الأورا numbness ممكن نشك فيه sensory strip. If the aura is myoclonus over the hand, we can think about the cortex of the precentral gyrus around the hand area. If the aura is more of visual flashes, we can think about the occipital, etc. And semiology is the seizure symptomatic zone. It's the area nearest to the seizure origin. So this patient has no aura, semiology staring episode, bimanual automatism lasting for less than 1 minute, and myoclonic jerk. So it is more of the frontalish. And drop things throughout the day. The seizure frequency is daily. And last seizure, generalized tonic-clonic seizure, was 1 year ago. So they are with medication, they are better controlled. Okay, but the seizure frequency daily, this is quite too much. The hypothesis is left frontal lobe epilepsy onset. Her PET scan was negative. MIG was potential epileptogenic dipoles within wide area covering large part of the left frontal lobe. So this is a big area around the frontal lobe on the left side. And we know that the frontal lobe on the left side, it has the Broca's area of the speech, it has the executive function of the brain, it has also motor over the anterior to the central sulcus. So what we did is that we implanted the patient head with electrodes, and this is our implantation. It takes a real effort to make those implantation, and it takes the longest time. We covered also the insula here. And after that, we did the surgery where we used the robot, and this is the drilling part. We drilled the electrode here. We make a specific measurement, and here we have the electrode implanted already to the patient's head. So after implantation, we did also some reading initially after stopping the patient medication. We did the reading, and then we found that the seizure focus is here around this sulcus, and a little bit was here, but this is only spread for the seizure. So this is the main area. So the decision was to go for resection of this area only, sparing the inferior frontal gyrus where the Broca's is. So this is after our planning for resection, and this is the patient and her seizure. So she has this chapeau de jagme, where she did this certain facial expression as like this with her mouth, if you notice here in this picture. So this indicates that this area is the epileptogenic zone, and the cingulate is the area of the nearest area of the symptomatic zone. So the symptoms arrive from this area, which is this facial pouting. We did the resection for this patient of this area included in the planning, and we did the pre-surgical 3D trials to include all the active electrodes. And this is a video, I think. No, sorry. And this is the area of resection. I delineate inside. Sorry. Yeah, and this is the area of the resection. We included all of the electrodes. This is a hole for one electrode. This is another electrode. This is the third electrode from the back, and this is one electrode as well. So we resected this area of interest, and it was showing focal cortical dysplasia type 1A, increased heterotropic neurons within the white matter, and the surgical outcome was Angel class 1B with follow-up of 2 years with improving quality of life. This lady was afraid from going to social gathering, and after that she went to live her life fully, alhamdulillah. The case number 2 is an interesting case where the patient was since childhood. She was right-handed female with a left hemispheric seizure onset. His seizure started at age of 7. The seizure description, the aura was tingling sensation over the groin area that descends to both legs with fear screaming. Rarely followed by lapse of awareness, tonic posture of both arms for less than 1 minute, followed by fatigue. Most of her events were nocturnal and generalized tonic-clonic once in her life. The seizure frequency was almost, I think it was quite a lot. I didn't write it here, but she's having the aura frequently, but not clear how frequent. According to the family, it's almost twice weekly. Yeah, the generalized tonic-clonic, she has it once, but the seizure risk factors, none. The hypothesis was the left hemisphere. And there was like a haziness here around the area of the ventricle. We thought this is the transmantle sign of the focal cortical dysplasia. So we have implanted the left frontal, left insula, left anterior cingulate, and the MRI was suggestive of focal cortical dysplasia. PET scan was done, but the area was not very well clear. After implantation and the stimulation, we did induce habitual seizure where she feels this groin intense pain, and resection cavity was demarcated by the electrode. You can see here the electrodes, and then this is the resection cavity. And it revealed focal cortical dysplasia type 2A, and the Angel class after resection was 1A, with follow-up after, now she reaches 3 years, honestly, and she has improved quality of life, and she's back to normal, alhamdulillah. Yeah, we'll come to that and to the questions in the end, inshallah. So this is her post-operative CT scan. The resected cavity is here. This is the frontal, superior frontal sulcus is just falling down with gravity. So the third case is a patient who's 30 years old, right-handed gentleman, known to have bitemporal lobe epilepsy. Both sides of the temporal lobes are affected. So can we resect both sides? Of course, no, because of the chance of having the Clover-Bessie syndrome if the patient lost both amygdala. So at this stage, we have to identify whether the seizure arises from one hemisphere and is spreading quickly to the other. That's why it shows bitemporal on the scalp EEG. The patient seizure description, the aura was uprising gastric sensation, and the semiology was lapse of awareness, oral and manual automatism with incoherent speech, interrupted speech. So it sometimes evolved to generalized bilateral tonic-clonic. And the frequency of seizure was generalized bilateral tonic-clonic every 4 months, which is a lot. The temporal seizures are usually very light, but having it progressing to bilateral tonic-clonic, this is very serious. And if it was lifted without any intervention, it can cause further kindling to the other side if the other side was not generating seizures on its own. The focal seizures with impaired awareness is weekly. The seizures risk factor, he has a younger brother with epilepsy that started as childhood. So in this patient, we suspected left-sided mesial temporal sclerosis, but the scalp EEG was showing 50-50. And also the PET scan was showing bilateral temporal reduced FDG metabolism. And the video EMG was showing 3 seizures arose from the left temporal and 3 from the right temporal. Neuropsychological assessment was performed, and he has acceptable cognitive function, and there was no clear lateralization, but his dominant hemisphere was the left side. Hypothesis was bitemporal lobe epilepsy. The phase 2 invasive robotic ECG with EMU monitoring. So the functional MRI was performed, and it was showing the left dominant hemisphere on the the Wernicke was on the right side, but the Broca's was represented bilaterally. And this is post-implantation. We implanted both sides of the temporal lobes with the electrodes as you see here in the pictures. So post ECG implantation, there is metallic artifact. So we have very specific CT scan modality to perform to reduce metal artifact, and no subdural no, and you have to check on the CT scan for subdural hemorrhage, intracranial hemorrhage or edema, la samah Allah. Straight electrodes means that there is no kinking, no deviation, no abnormalities on the picture. And it can be used for the quality check on the NeuroMate software, so you can check whether the implantation it goes well with the initial planning. After resection, so the patient was identified to have left-sided temporal lobe seizure origin. So the resection was performed, and this is the CT scan showing the resection of the left temporal. And the histopathology came out as focal cortical dysplasia type 3A, where there is cortical lamination abnormalities in the temporal lobe associated with hippocampal sclerosis and mesial temporal sclerosis as well. So the patient also has a very good outcome with the Angel 1A in the 3 years follow-up and improved quality of life. Yeah, this is another one also, just to have an idea about the epilepsy surgery and how it goes. Those are very focused examples. For this case, this is the fourth case about a lady who's 38, right-handed female. Her seizure began at the age of 28, initially presented with fever, loss of consciousness, treated as autoimmune encephalitis. And then she developed this frequent seizures where she has left-sided numbness, progressive from feet to face. It goes from feet to face, and then it has right manual automatism. Automatism usually on the same side of the seizure origin. The manifestation always opposite. And left facial and hand twitches with saliva drooling and the occasional loss of awareness. The frequency is 3 to 4 episodes per week, and the treatment regimen was levetiracetam, Vimpat, and pyramidal, but she's still very resistant. This is her PET scan. It is showing faint left-sided parietal abnormality or reduced metabolism in the right parietal lesion, but the area is very diffuse and white. You cannot rely on it for resection. EEG was showing some distinct abnormality in T4, P4, T6, P4, but it wasn't very well demarcated. The MRI was not very specific. So we have implanted her generously about the parietal area, including the temporal as well as somatosensory area. And we have found that the right parieto-temporal seizure onset, and we identified the seizure origin in the right superior parietal lobule. So the resection was performed, and the patient had some seizure freedom after that for a couple of weeks, and then she started to develop some different type of seizures, for which is autoimmune encephalitis is a diffuse disease. So this is the main disabling seizures for her disease, but she still have some residual seizures coming from the occipital as well as temporal, but they are not disabling ones. Sorry, 1 second, please. Yes, معلش دقايق. كم باقي عليه؟ طيب نص ساعة حبيبي. طيب yeah, my apologies for that. So this is the next case. Yeah, so this case is very interesting and dear to my heart. This is a 19 years old young adult young adult, Muhammad. He has difficulties at school. He has never been able to drive. He has no hobbies, no friends. He was severely depressed. He had some suicidal ideation, and he stated that very clearly that he will kill himself after some of the seizures episodes. So this patient has the seizure where he start to see some items, some faces, and those faces are stretched and becoming very scary. So he feels really scared after each seizure, and he really fear to see it again, and he feels like he really want to end his life because of that. I can repeat his image, his EEG, and this is the meaning of EMU admission, where we put a camera to see the seizure semiology and link it to what is the patient describing. So he's clearly fearful and afraid from whatever he saw. He's touching his heart to calm himself, and he's looking at certain area of the visual field. So we implanted him with extensive coverage over the left side and little coverage over the right side, because the main pathology was likely to be on the left side. And after that, we identified the seizure focus to be here on the left occipital, area, afwan, here, above and below the calcarine fissure. So in this area, in this situation, we wanted to rule out the visual deficit. So we did the baseline examination for the patient. And here is the seizure onset in the left anterior inferior occipital. And here where he sees the dots, then the faces. And here also the spread in the left posterior parahippocampal after the seizure starting on the occipital. And here where he looks fearful and distressed, where it reaches the left left anterior hippocampus and amygdala. So as the seizure starts in the occipital area, where he sees some visual elements, and then the seizure goes, because the seizure is a network disease, so it goes and travels anteriorly to the hippocampus, to the parahippocampus, to the amygdala. The amygdala is the organ of fear. Here where he looks very fearful and distressed. So the decision to resection and accepting any further deficit over the visual cortex was acceptable in this case, because this is you cannot perform here neuromodulation in a patient who has risk of suicidal tendency, because neuromodulation can aggravate those symptoms. So the main area here to treat the patient is the resection, and we had the baseline image, and we sat with the patients and his family, and very thorough discussion about the possible decrease in the visual field was illustrated very clearly, and the patients with his family has accepted this risk, and they have signed informed consent, and they were happy about proceeding with the surgery, where the origin was started here in the left anterior inferior occipital and travels all the way to the amygdala. Direct cortical stimulation, we were able to induce his habitual seizure. So when we throw those electrodes there, we can also return his medications and keep him calm, but we induce by ourselves some with certain calibration. We induce seizure by electrical stimulation on our own. So if we match the area of the electrode with the seizure onset that has been recorded on the video, this is a very good success or indication of a good prognostication. So here is the stimulation has created seizure in the same area where we had suspected the seizure onset zone. So this is a very good way of bringing up or confirming the seizure origin. Yeah, for the parameter for direct cortical stimulation, yeah, we start very low. We start here with the stimulation, we start with the stimulation very low, and then here with the pulse width, we have some certain fixed parameters for the frequency and the duration and pulse width, but for the electrical stimulation, we start with 1 milliampere with and then 2 milliamperes, and then in certain places 2 milliampere is enough to cause after discharge, and in some patients we reach up to 6 milliamperes, where they sometimes they have generalized tonic-clonic seizures and sometimes status. So we keep the patient under EMU, and we prepare midazolam in case the patient progress to generalized tonic-clonic seizures with our stimulation. So usually at 2 milliampere, they show some after discharge, which is enough for delineation of the seizure onset. Okay. So this is the resection cavity, and this is the resected part of the occipital lobe. This is the occiput, and this is the part that was resected. And here is the electrodes coming out from the resected cavity. Here it is, and this is the area. So he does have a visual deficit, but it is more acceptable to him than living with this horrific kind of seizure semiology. So the disconnective surgery, all what I spoke about, the 5 examples or 5 cases before, those about the resective surgeries. Some of them they had deficit. Most of them they have complete resolution of the seizures, and some of them they have some residual other kind of seizures. But mostly they had very good outcome with some extent of acceptable deficit. Okay. Now we'll be talking about the disconnective surgery, like in the functional hemispherotomy, corpus callosotomy, or multiple subpial transection. So we have this hemispherotomy, functional hemispherotomy, corpus callosotomy, modified disconnection, like isolating the frontal lobe, isolating the temporal lobe, isolating the parietal lobe or posterior quadrant in general, including the parietal as well as the temporal and occipital with it. Or multiple subpial transection, which is very, very old technique, and it's losing its interest and falling out of favor. Why is that? Because of the new neuromodulation techniques. So the hemispherotomy is disconnecting part of the hemisphere from the other if we are sure about the seizure origin from one area only, from one side of the brain only. So if this is one of my patients, yeah, I did recently. She had right-sided right-sided left-sided seizure origin, and due to traumatic brain insult. So I just did the disconnection here, peri-insular. The type of disconnection I do is the peri-insular disconnection. And then it has also corpus callosotomy, but from inside the ventricle. And then I do some decortication of the insular part. So this is the patient's MRI. You can recognize here the peri-insular resection, the anterior disconnection from here, the corpus callosotomy, all the way till the back. All the way till the back, here is the back, and temporal resection for that patient, or disconnection is enough only. So this is for cases like hemimegalencephaly, Rasmussen encephalitis, large perinatal stroke, or traumatic injury to one side of the brain. So it has the possibility of losing ability to walk if the patient is old, above 8 years old. But usually we do it in the pediatrics, so we have the chance of getting some brain plasticity and shifting function from one side of the brain to the other. Corpus callosotomy is the area where we do disconnection of the right and left from top, from the corpus callosum here. And the idea is this disconnect the spread of the generalized seizure, like in Lennox-Gastaut syndrome or drop attack. It's the best for the drop attack of the generalized seizures. But it is palliative procedure. Modified disconnection according to the lobe, whether it's anterior, it is posterior, it is anterior quadrant, or echo-guided. Sorry. The multiple subpial transection is a very smart idea, honestly. It's where you disconnect the horizontally connected neurons to each other by doing this disconnection using hook-like technique to disrupt the lateral spread of the neurons activity to the other side. So as I said before, if there is a fire in one house inside a city, you contain this or disconnected from the other other neighbors or neighbors inside the same district. And this is the same idea. You disconnect the neurons, horizontal neurons laterally, so you prevent further spread. But the issue with that is that it is still very limited, because the depth of the sulcus always has some neurons that cannot be disconnected also from the surrounding. Otherwise, you will cause some type of hemorrhagic insult if you tackle this portion of the deep sulcus. So this can be performed as adjunct to the surrounding, like here, for instance, if there is an area that can be resected, you resect it, but the other area is eloquent, so you do it on the مثلا motor hemisphere, motor strip or sensory strip to avoid the spread of the seizures. I don't think you will see it in real life, but it's good to know about it, because it stimulates your mind to think about other areas to tackle epilepsy. The third modality is the neuromodulation. Afwan, sorry, I have a very important call from the hospital.
Afnan, this patient, Juhaina, she is stable. Regarding this overall, this lady, 96 years old, with anesthesia.
Okay, so the other modality is the neuroablative, where the radiofrequency lesioning can be performed. And how can we use the radiofrequency lesioning? You remember those electrodes of SEEG? We can do not only stimulation, as you asked about the parameters of 1 milliampere, 2 milliampere, we can raise it up with the radiofrequency and do some burning lesioning. It is kind of palliative, so it gives the patient some honeymoon phase till we do the actual resection surgery, or we can do it if the area is not resectable and we want to do some lesioning to disrupt the network of the epilepsy. The second modality is the laser interstitial thermal therapy, LIT, where we can do some lesioning to certain areas that are very deep and surgically inaccessible, like the insula. Or the focus ultrasound, where we can do some lesioning like in the cerebellum or STN, or some targets for treatment of the epilepsy. I have some pictures about the radio frequency. Those are the electrodes we're using in the SEEG, and this is after stimulation. We can do lesioning by like radio frequency. We can use it. We can do here like two continuous or contagious contacts, or two adjacent ones. We can do burning in between if they are less than 1 centimeter, or we can do on opposite electrodes to have a bigger insult. or bigger burning area to disrupt the function. And this is the machine to be used for the stimulation and radio frequency ablation. Laser interstitial thermal therapy is a very expensive needle that goes all the way to the certain area of the brain, like the insula. We can use one or two or multiple trajectories to burn the area of the insula that is generating the seizure focus. This is the laser needle, and it has to be done inside the MRI, as it is MRI guided interstitial thermal therapy. It has a very safe, very high safety profile. The focus ultrasound is a lesioning. It's just like DBS, but with lesioning instead of the stimulation. The neuromodulation, this is the fourth category of epilepsy surgery, where we, instead of resection, we can just implant some electrical device and give it some stimulation parameters with permanent device inside the body, like vagal nerve stimulation, deep brain stimulation, or responsive neuro stimulation. It has seizure reduction rather than cure. Always in my clinic, when I talk about the neuromodulation for the patient, I tell them this is a device that can help in seizure reduction, but I cannot promise you to stop your anti-seizures medications. Okay, so if the anti-seizures medications are chemicals or chemistry, the neuromodulation are physics. So there are some certain electricity that shut down the electrical spread in the brain. For those modalities, we don't remove part of the brain cells, but we are modifying their behaviors. So they are kind of AI tool inside the brain, and they are the cornerstone for the brain machine interface in the coming future. It's not even a future, like a lot of applications nowadays, but it's not yet medically approved or FDA approved. So the approved one are those medical things. The vagal nerve stimulation, مثلا, it is a palliation that is used for generalized type of epilepsy, not localized. If it is localized with one or two foci, we can choose the RNS or deep brain stimulation. The DBS is more of lateralized but not focalized, and RNS is for more focalized epilepsy. The vagal nerve stimulator is this device that can go around the vagal nerve, like a telephone wire, and it goes around the vagal nerve, 3 pieces, hugs the nerve, and then it goes all around till beyond the clavicle in the chest for implantation. Possible target, the DBS also is another modality. This is very less invasive in the neck and chest, so the people favor vagal nerve stimulation. It's more common than the other neuromodulation techniques because of its easy procedure, and it's outside the brain, a vagal nerve in the neck and the battery on the chest. Whereas the deep brain stimulation, it has certain targets like cerebellum, hippocampus, subthalamic nucleus, centromedian nucleus, caudate, lucus ceruleus, and those stuff for stimulation. I'll not go through each one in details. The anterior thalamic nucleus, it has Sante trial, and centromedian nucleus has Estel trial with all of the inclusion-exclusion criteria. Pulvinar is more emerging in the thalamus. Those are nuclei within the thalamus. And those targets are circuit-based. For example, anterior thalamic nucleus is more of the temporalish seizure. Centromedial is more of the generalized motor. And pulvinar is more of the posterior network epilepsy, posterior quadrant. The RNS is a device where the battery will stay on top of the head. And the target will go directly to 2 foci in the brain. And the downside about it is that it's not approved outside the United States because of the main data computer or the main data set of the patients will be inside United States, and they are not allowed to go outside the States. So it has some patients' privacy issues and is not yet approved outside America. The future of epilepsy neuromodulation, as I said before, the optogenetics, nanotechnology, gene therapy. I think gene therapy is taking a big burden in the future. Tissue transplant, as a lot of studies about the stem cells and pluripotent stem cell implantation. Brain-computer interface, I think this is a very likely growing field. Hopefully, it takes it gives hope to some disabled patients that cannot function well or their life is limited due to their functional losses. So we're trying to integrate the artificial intelligence with our network, the epilepsy surgeries as much as possible. We're using robotics, closed loop systems, AI as a prediction of outcome. We've done some studies about the implantation, where to implant, whom to implant. We use large language models to predict that, and we compared the large language model capability using 5 different modalities with expert opinion, and we have found some good comparable results. The other AI-based study is about the machine learning to stratify the ictal ECG pattern and optimizing epilepsy surgery outcome. As I told you before, the best surgical outcome for the temporal lobe is 80%. So if you did the temporal lobectomy on 100 patients, 80%, 80 of them will have seizure cure, but still 20% they will still have seizures. So we try to have to study all of the information about those patients who did better and identify the pattern. So this is where the machine learning can find some similarities and grasp them out, or highlighting those similarities to give us clearer idea about the patient who does better than the patient who do poorly after surgery. We can have those information after 30 years of practice, where we call it experience. But for machine learning, you just feed the system with the information and the data, and they find the similarities and the differences between the patient who did better or did worse. So this is also machine learning to guide surgical planning in refractory focal epilepsy from direct cortical stimulation and interictal discharge zone. So this is the last I'll talk about, which is also about our stimulation. We compared the patient whom had cortical stimulation with ECG, as I mentioned before, but they had after discharge in area within this epileptic network versus area far away from epileptic network. So although this study is negative, but it concludes that resection of the area that is far from the epileptic network has no difference than in the success rate for the surgical resection outcome from resecting the area that is only close to the epileptic network. So although this is a negative study, but it has a very good clinical value. And we're still in the beginning of the AI integration with the surgical field. So we hope that one day, inshallah, will come up with a very curative pathway and a better patients controlling outcome. You're free to ask any question, and sorry if I talk too much and interrupted in between. I'll go to your questions in the chat box. There is a question about the tuberous sclerosis with multiple tubers in the frontal lobe causing intractable epilepsy. What about the surgical option? Yeah, in the tuberous sclerosis, there is a very good biological agent, which is everolimus. No, sorry, the medication for tuberous sclerosis is I forgot the name of that medication. Tuberous sclerosis complex. The mTOR inhibitor, which is everolimus, yes, and sirolimus, they are very good for the tubers. So most of those cases, they go more into medical treatment rather than surgical because they are a lot of the tubers. They all coming like candles, drips all over the ventricle. It's very difficult to resect all of them. And they respond very well to mTOR inhibitors. But the downside about the mTOR inhibitors is that they are very costly. Number two, that they need to be on those medications lifelong. Whenever they stop it, they come back or they regrow. Does any patient use 2 or more anticonvulsants be candidate for epilepsy surgery? This question is yes and no. So they are 2 or more are drug resistant epilepsy. طيب 2 or more are drug resistant epilepsy, but are they candidate or not? We will know. We will investigate if they are having مثلا very clear focus, we can think about resective surgery. If they don't have very clear focus, we can think about neuromodulation. طيب. But if, for instance, they are very hyperactive and they are taking scratching the area of surgery, they can't control themselves. Even the neuromodulation is a bit difficult for them. So we can do مثلا neuroablation. Or if the area of the surgery is over the motor strip, for instance, or something else. So we cannot label all the patients are candidate for surgery. They might be candidate of surgery. That's why we have to investigate them more and more. Is there a way to confirm the successful resection margin intraoperatively? Intraoperatively, we use the ECOG guidance. Sometimes we put the ECOG on top of the tumor margin resection margin. If there is no more electrical discharges, it's well and good. But what happens usually in real life, if we put the grid on top of the resection cavity, the resection itself will create a false positive electrical discharges around the resection area. That's why in all epilepsy surgeries, we don't stop anti-epileptic medications instantly. It's not like a pain surgery where you stop the medications right away. No, in epilepsy surgery, the surrounding area will still be firing a little bit till they recognize the new network that is formed without this seizure focus. So the protocol is to keep the patient on the same dose, same types of anti-seizure medication for at least 6 months or up to 1 year till we start tapering the anti-seizures medication, because any brain surgery on its own can cause seizures immediately after surgery, in the first 2 weeks after surgery especially.
Thank you so much, Dr. Afnan, for this insightful and enriching session. I truly appreciate your time, knowledge, and expertise you've shared with us today.
Thank you. Thank you so much. I think there are some quick questions why we don't move toward neuromodulation rather than continue pursuing resective surgery, because the cure rate is much better in resective surgery than neuromodulation. Neuromodulation is the best occasion is removing 50% of the seizures. Any specific drug for seizures after epilepsy surgery? No, they continue on their own previously well-selected drugs before surgery on their previous regimen. Yeah, thank you so much. If you have any questions, this is my email, and I hope you enjoyed my time, your time here, mashallah, from Morocco. I'm very pleased and honored to join you today, and feel free to contact me at any time. And Allah يوفقكم يا رب جميعا.
Thank you so much, Dr. I'd like to express my deepest appreciation to you, Dr. Afnan, for your support and your knowledge you've shared with us today. And thank you all for attending and engaging with us today. See you, inshallah, in our future webinars. Thank you and have a wonderful evening.
You too. Thank you so much. Bye-bye.
Bye-bye.